I'm Dr. Megan Pesch. Thank you for joining me this afternoon or this evening, depending on where you're joining from. Today, I have the pleasure of talking to you about congenital cytomegalovirus, or CMV, and I'm going to make the case for newborn screening. A little bit about myself before we dig in. So I am president-elect of the National CMV Foundation. And we do a lot of advocacy around CMV screening and awareness. I'm also an assistant professor of Developmental and Behavioral Pediatrics at the University of Michigan, and I run our Congenital CMV developmental follow-up clinic there, which is a ton of fun. So I'm excited to get to talk to you about one of my favorite topics today. So quick disclosures. So I did say I am affiliated with the National CMV Foundation. I am a consultant for Diasorin Molecular and Medscape. I have research funding from the Gerber Foundation and the American Heart Association. This talk was sponsored by Diasorin Molecular, although they didn't have any contributions in terms of the content or, telling me what to say. So briefly, I wanted to talk about the learning objectives for today, just to give you an overview of where we're going. So I'm going to summarize the prevalence, talk about disease manifestation, treatment, and management of congenital CMV. I want to talk about current clinical guidelines and laboratory methods used to diagnose congenital CMV infections. And then briefly, we'll touch on some new screening approaches, as well as some legislative updates here in the US. So I know I've got a pretty broad audience here, so I just wanted to take a step back and make sure we're all on the same. Here we go. There, my slide caught up. So I want to take a step back and make sure we're all on the same page in terms of what we're talking about here. So cytomegalovirus, or CMV, it's a common DNA virus. Again, this is like the Delta Airlines, view from 30,000 feet. It infects people of all ages. And, by around 40, about 60% of US adults will have been exposed and infected at some time. And in developing countries, possibly up to 90%, depending on the study. So it is a ubiquitous virus. It is everywhere. So a bit more, CMV is found in all tissues. It is latent and becomes latent in lymphocytes and monocytes. And throughout the life course of the host, CMV is intermittently reactivated. There are primary CMV infections where someone is infected with CMV for the very first time. And then non-primary infections, which include, reactivation. Also, if someone was to get another strain of the virus, which we all know happens all the time. And I feel like the general public has had a crash course in this with COVID recently, unfortunately. Important to know about CMV is that most healthy individuals have no symptoms or very, very mild symptoms. Like some people might have some fatigue or some lymph nodes, but the majority of people are asymptomatic. And it's really kind of an infection that you probably would never know you had unless you were immunosuppressed or kind of in these these specific groups. Now, CMV, before we dive into congenital CMV, which is when a infant, or a fetus, I should say, is infected via the placenta in utero. But other diseases associated with CMV include mononucleosis. They can go hand in hand. We see CMV pneumonia, as well as cardiac infections, CNS infections, GI infections, retinitis, hepatitis. And, I think you hear a lot about CMV when talking about AIDS or immunosuppression, because it really is a virus that can be really ugly in those populations, organ transplant as well, who are immunosuppressed. So CMV is transmitted through bodily fluids. I've got a drooly baby here. I'm a pediatrician, so I see a lot of drooly babies in clinic, and saliva, especially of young children, seems to be a way that it is transmitted quite frequently. I've got a little baby sleeping here beside me too, so apologies if you hear any noises. Just wanted to kind of give you a heads up in advance. And so CMV can be transmitted in almost any bodily fluid. So tears, urine, sexual fluids, so, vaginal secretions, semen, breast milk is a big one. And then, of course, like in the blood, like through the placenta, which is how we get congenital CMV. And as a reminder, so horizontal transmission is when the virus, in this case CMV, is transmitted from one person outside the uterus, one born person to another born person. But vertical transmission is via the placenta to the fetus. And that's really where we see a lot of issues, and that is congenital CMV. So in a nutshell, as I said, the fetus is infected in utero. So what? So this is the leading non-genetic cause of neonatal and childhood hearing loss. There's also some risk of neurodevelopmental delays, and a little bit later, I'm going to go through kind of in broad strokes the neuropathogenesis of CMV, congenital CMV, which will really help tie together kind of why there are these possible sequelae. Here's a statistic that blows my mind. Roughly 30,000 U.S. infants are born with congenital CMV each year. So another way to look at that is that's 1 in 200 U.S. infants, which is so high. And I think, people have called it the most common virus that no one knows about or no one's talking about. And again, in the general public, there really just has not been this public health discourse about CMV, even though it's been around forever and we've known about it forever. I have a lot of theories, but it is out there and it is really common. So to really hammer this point home, congenital CMV is more common than all the disorders, so the endocrine and metabolic disorders screened for on the recommended uniform screening panel, which is the national panel that is recommended that states screen for newborn screening. So all those conditions combined, more common than trisomy 21 or Down syndrome, pediatric HIV, fetal alcohol syndrome, and these other, congenital listeria and toxoplasmosis. When we're pregnant, we hear all about don't eat soft cheeses, don't eat lunch meat, don't scoop the kitty litter, but which is important. I'm not minimizing that, but we don't typically hear a lot about CMV prevention, which is a problem. And I'm happy to say that seems to be changing. This figure here, I'll just walk you through it really quickly. So it's awareness versus incidence of congenital conditions in the US. So that top x-axis is the number of children disabled by the condition each year. And those are the orange circles or dots there. The bars represent the percentage of women who have even heard of that condition. And so you can see going down second to last there, you see Down syndrome, trisomy 21. So roughly 90%, I'm going to say, of women, that's the blue bar, have heard of Down syndrome. And roughly just under 6,000 children each year are disabled, born with trisomy 21. So, on this scale, those are about equal awareness and incidence. But then going up to that very top bar for congenital CMV, excuse me, you can see that only about 9% of women have heard of congenital CMV, yet that dot of how many, the incidence is way out there, similar to trisomy 21 at around 6,000. And so the 6,000 is the number of babies that are thought to be disabled long-term by the condition. Yet, as you may recall, I mentioned earlier, around 30,000 babies are born with congenital CMV. So a large percentage of them will do well and not have long-term disabilities. So I just wanted to clarify that. So why aren't we talking about congenital CMV? And I'm glad to say that we are starting to talk about congenital CMV, but it has taken a while. I think people talk about it as a silent virus, meaning that meaning that it can cause hearing loss. It also is silent in terms of being, folks are usually asymptomatic. Even babies born with congenital CMV, for the most part, you cannot identify them just, looking at them or clinically examining them. You have to test. And, also until recently, there wasn't much progress in terms of vaccine development or really antiviral treatment. So I think it was something we weren't talking about because it wasn't really in our faces and we didn't really know what we could do about it. But that is changing, which I'll touch on in a bit. Okay, let's see. I've got some animations here. I'll just explain the whole thing. So here we've got a schematic of kind of the life cycle of congenital CMV or CMV and how it can become congenital CMV. So I'll start at that top orange arrow, seropositive mothers. So women who have had CMV in the past or a current infection can and often do shed the virus in their breast milk. So it depends on the study, but 30 to 70% of women can be shedding CMV in their breast milk at any time. This then can infect the nursing infant, and of those nursing infants, around 50% will be infected. And, this is acquiring CMV through breast milk is generally not harmful at all. Really, the exception is for those, super preemie babies or medically vulnerable infants. But then, the child or infant is infected and grows up and then can pass that infection through saliva, tears, urine, through a reactivation or whatnot to people who are in close contact with them. And people that they are sharing bodily fluids with. Now, if any of you have a toddler at home or have seen a toddler, they are sharing bodily fluids with everyone. There's diapers and they're putting things in their mouths and daycares are actually is a reservoir almost for this infection, meaning that when children have a CMV infection, they continue to shed the virus for months and months after any symptoms, if they even had any, were present. So, then it just passes around the daycare, and then these kids can then bring it back to other people they have close contact with, which namely, in this situation, is mom. So congenital CMV is more common in second or third babies. And when folks have looked at the strain of virus from infected in the baby born with congenital CMV, it is often also present in the older sibling. So to reduce CMV risk, it's really a lot about, hygiene as best as you can. But if a baby acquires it from nursing, we don't want to discourage breastfeeding. It's wonderful. So this is really why we need a vaccine. Individuals who work with children can take precautions to protect themselves from a second infection or another strain or a primary infection. And, this is things like not sharing food with young children, not kissing on the lips, at least during that pregnancy window or even before pregnancy. Don't share straws, really double down on the hand washing after diaper changes. It's interesting. There's a study from Portugal, I believe, that showed that the incidence of congenital CMV, the prevalence went down during the height of the COVID pandemic in 2020 when all the daycares were closed and kids were home with their their families. And so there wasn't kind of that transmission at daycare. That's the theory, at least. And there have been some really nice studies recently that have shown that prenatal counseling about these behavioral changes can actually impact the behavior in pregnancy. And, the hope is then it will lower the risk of seroconversion and then transmission to the fetus. I should say it won't lower transmission to the fetus, but if the mom doesn't have it circulating in her system, then that won't transmit to the fetus. I think you get what I'm saying. So these are just kind of 5 simple tips. Don't share a toothbrush. Don't do the thing where when the pacifier falls on the ground, you like clean it by putting it in your mouth. Like, it sounds gross, but like so many people do it, and then put it in the baby's mouth, things like that. So of women who get CMV circulating, an active infection or reinfection in pregnancy, about a third is actually transmitted to the fetus. It is also thought to be the leading cause of viral cause of intrauterine fetal demise and pregnancy loss. This is something that there's emerging research on. But it has been really interesting to kind of see this new, area, I think, that is really under-recognized. And then, of course, the primary infection then becomes dormant or latent, and then there are those reactivations, which we touched on. The transmission to the fetus there's an increased risk of transmission in primary infections, yet the majority of infants with CMV are born to mothers with non-primary infections, meaning either a new strain or a reactivation. And that's just because so many people have been exposed to CMV. So just like sheer numbers. I'm just going to click through. All right, here we go. So of the babies, I'm going to start with this orange box. Of the mothers who are CMV positive, so seropositive with a non-primary infection, around 3% of them will transmit to the fetus. And a CMV negative over here, mom, so seronegative with a primary infection, this should just say primary infection, not reinfection. A primary infection, around 40% of that will transmit to the fetus. And, the sequelae are hearing loss, CNS sequelae, and then, of course, always concerned for pregnancy loss and miscarriage. The severity of CMV in terms of its impact on the fetus, it's most severe the earlier in pregnancy the virus is transmitted. And that just makes sense because you think of all the downstream structures and, just like creation of organs and, brain development that can happen if one of those early kind of precursors is affected. Interestingly, though, transmission is much more likely later in the pregnancy. And so I think that's, likely due to blood flow and placental blood flow, but the potential impact is not as great. So thinking of mechanisms of fetal injury, there are 3 main mechanisms that, causes the fetus to be injured from this virus. So placental injury, there can be a lot of like vasculopathy, inflammation in the placenta, which can result in like end organ damage, really like, insufficient blood flow. Infants can be born with growth restriction. There's also viral replication actually in fetal cells, and especially this is a neurotropic virus, meaning it loves like fetal CNS cells. And so it can disrupt development, and downstream effects of that can be very significant. And then there's also the maternal immune response. Some antibodies and inflammation to fight off the infection is a good thing, but too much is not. And so with all that going on with the immune response, we can have disrupted cell replication and apoptosis. So this is just a broad overview of what can go wrong, but it can be a lot. And the virus does, thinking about how it affects the fetal brain, replicates in astrocytes, neurons, microglia. There are more. The earlier infections can disrupt cortical development, and also, interestingly, CMV can affect host gene expression. So recently, there was a really cool study, and I hope I'm getting this right, that found that CMV can actually, let's see, I think it was turn off a gene that prevents or decreases the likelihood of like lissencephaly. I might have that backwards. It might turn on a gene, but it can affect that gene host expression, and the downstream effects of that, you can actually sometimes physically see in the fetus. And so thinking about all the ways that this virus can affect a fetal brain, the neurodevelopmental outcomes then follow. So intellectual disability, learning disabilities, hearing loss, vestibular disorders, meaning like balance, gaze tracking, cerebral palsy, motor planning disorders, epilepsy, autism as well. And I put a star next to that because this is an area of developing research, but I think it's fascinating. And clinically, I've seen a lot of autism in my patients. Also, visual loss or impairment from the inflammation in the eye. In general, we're seeing about 20% of all comers with congenital CMV have hearing loss by 18 years old. 60% of infants with signs at birth, so those are the sickest, will have long-term disabilities. But again, looking at all comers, we're thinking about 75% will have largely typical outcomes based on what we know right now in the literature, which is actually really, I think, really encouraging. I want to shift now to talk about the presentation at birth. So right now, by and large, CMV is kind of categorized by whether or not, or the severity of congenital CMV is categorized by whether or not an infant is born with visible signs at birth. So most infants with congenital CMV are born asymptomatic. I put that in like air quotes because we'll talk about that in a little bit about, do they truly have no symptoms? And these babies have no clinical signs at birth, no blood tests that indicate that, no low platelets or, blood tests that indicate that there is like some liver inflammation or hepatitis going on. But these babies can still have hearing loss, and they can have profound hearing loss at birth. But as long as the labs are okay and the head imaging is okay and they look okay at birth, they're still asymptomatic. 10% are symptomatic, meaning they have those visible signs at birth, laboratory abnormalities, or intracranial findings on imaging when a head ultrasound or MRI is done. So this is kind of a baby. Sometimes we talk about the blueberry muffin baby or blueberry muffin rash. And this is a little girl. She actually lives in Germany. She's like 9 or 10 now and gave me permission to use this picture. But this is symptomatic disease, and that's having one or more of these signs at birth. So small for gestational age, microcephaly, small head. This petechial rash, which you can see on her, there's like pinpoint little like purple dots. Jaundice, and it's a particular type of jaundice. It's not just like run-of-the-mill jaundice. Enlarged liver and spleen, seizures. There are the other things like intracranial findings, so abnormalities in how the brain formed, or some like hallmarks of CMV inflammation, like calcifications in the brain, and again, the laboratory abnormalities. This does not take into account hearing loss. And these two latter findings are not visible, right? You can't see them unless you know to look for them. So it is So that baby, I should say, is a baby who is severely affected by CMV. But like I said, it is the silent leading viral cause of birth defects in the US, because, here I want to show you another picture of a severely affected baby. And so this here, I can't help but smile. This is my third daughter. Her name's Odessa, and she was born with severely symptomatic congenital CMV, but you would never have known it, and I didn't know it. Nobody knew it just by looking at her. Look at that perfect head. She's so sweet. I had a very seemingly typical pregnancy with her. I delivered at term. It was kind of a messy delivery. So she did have some little spots on her forehead, but you can see that with a lot of babies. She did fail her newborn hearing screen, but I had spent my whole career reassuring moms that it was likely a false positive, because the false positive rate for a newborn hearing screen is roughly 90%. So, after her delivery being a bit rough, I was like, of course, I'm not worried. And I was determined to go home and not be one of those worried moms. Well, I mean, of course, like you can see where this is going. We took her home. We, enjoyed our like crazy, hectic first couple months as a family of 5. These children were very young. It was really hectic. And then when she was around 2.5 months, I took her in for her repeat hearing screen, thinking it would just be whatever, like another thing we were checking off. But unfortunately, she was found to have profound bilateral hearing loss, meaning 0 hearing. And when she was born, one of the reasons I wasn't worried about her hearing was that when her sisters would run around the room and drop things, she would startle. But by the time we had her hearing rechecked, what hearing she may have had at birth was gone. We went to see an otolaryngologist who is an excellent clinician, and we were told that it was likely genetic, which is true. That's the most common cause of hearing loss. And I asked about congenital CMV, not because I had some like maternal gut feeling or some like premonition. I was just like going through my list of things that I could like sort of remember from my training. And we were told that it's probably not CMV because she looks so normal. But long story short, we did find out it was. And then when we did a head ultrasound through her soft spot, there were multiple signs of CMV in her brain, which is heartbreaking. But it's extra heartbreaking because, had we known this at birth, she would have been eligible for antiviral medication, which has been shown to, modestly improve developmental outcomes at 24 months. That's the best study we have right now. But we kind of missed out on that window. And who knows if some of her hearing would have been preserved. But also, like looking back as a clinician, like I was staring at this kid 24 hours a day and I didn't see it. So I don't think that anybody like missed something at the hospital. This is just really why we need to screen for this in newborns. So Odessa, she got cochlear implants, and this is like where I used to stop the talk and be like, and now she's great, and look how sweet she is. She's almost 4. She's like so much bigger than this now. But really, this is her now. Things have been really tough. She has had global developmental delay. She could not hold her head up until she was 6 months old. And that was with like twice a week physical therapy, really intensive. We did do the antiviral medication, even though we were late, and I don't know if it had any effect, but it does have the effect of suppressing the immune system and causing neutropenia. So she had to be pulled out of daycare. Now she is on the autism spectrum. She, is deaf and is communicating through a mixture of sign and, spoken language. But gosh, it has been really hard. It is not just hearing loss. And, I think this is really like this is the reason why I became interested in CMV, and I'm trying to just, spread the word, not the virus, right? To really start talking about this, which it's a big public health problem. So 1% of babies with congenital CMV are thought to be diagnosed based on how they look. The other 99%, if you don't have a screening program, we're not catching them. And so, what about these asymptomatic babies, the ones that look normal or, don't have any findings, I should say? Well, the asymptomatic babies can still have hearing loss, as I mentioned, vestibular disorders, speech and language delays, which are tied to the hearing loss. They're low tone, they might walk late. And then I personally, as a developmental pediatrician, really worry about other conditions that maybe we just don't know enough about yet. And so, roughly 20% of these kids will have hearing loss by 18. That might be, 15 to 20%. Around half of them will have vestibular disorders and gaze stability dysfunctions. And there's some debate about whether or not that might translate into literacy difficulties. I don't know. And then 30% of asymptomatic kids will have balance difficulties. So, really asymptomatic is a confusing misnomer, and we just need to be done with it. You cannot categorize a complex disease like this into two buckets. You just can't. I also worry about, as I said, autism risk, learning disabilities, developmental delays that are subtle in these kids. The research hasn't been super robust in this area. So, this is something, I hope I'm wrong. I really hope I'm wrong. But this is kind of my hunch and something that I, am currently researching. I'm just going to summarize the slide quickly. This was a study from Europe that looked at 34 infants with known congenital CMV. They were screened at birth, but a normal physical exam. When they did labs, head imaging, hearing, and vision screening or testing, 56% of these babies ended up having one or more findings. And this was done in Europe, so their criteria for treatment is different, but you can 56%. So all of these babies did end up then meeting criteria for antiviral treatment. And these are all kind of the different things that they found. 45% of these kids, let me back up. 45% of the 56% had abnormal head imaging, which is massive, right? In terms of potential developmental outcomes and things that we can do in terms of intervention to support these kids. But if you don't look, you don't know. So clinically, congenital CMV, I see a lot of those kids, but autism is my first love and what has been my bread and butter of my career. Sorry, you can hear my little co-host. So I love a spectrum, and I think this is where we need to go in terms of congenital CMV. Babies might be born symptomatic or asymptomatic, but in terms of where they end up, in terms of whether or not they develop cerebral palsy or cognitive delays or hearing loss, I think kids are going to move kind of around this spectrum of severity. And you can't just predict that based on how someone looks at birth. There's so much, right, that goes into child development. And so this is kind of where I'm hoping we are headed. Next, I'm going to shift here to diagnosis and detection. So why screen for CMV? Hopefully I've started to make that point. You can't tell by looking at most babies. And babies, to diagnose congenital CMV, you have to test a specimen that has been collected before 21 days of age. After 21 days of age, it's been found that you really cannot tell a congenital infection from a postnatal infection, through breast milk or whatever, which postnatal infection is generally harmless. So before 21 days, one can test urine, saliva. Those are the preferred samples. Can also be found in, you can also do a dry blood spot PCR, although the sensitivity is much lower. But those are the ways that you can test before 21 days. After 21 days, you're really only left with that dried blood spot PCR because, that specimen was collected before 21 days of age. But a lot of these kids, if we're not screening at birth, they're not presenting with signs or symptoms until way after this 21 days of age. And so kids are getting missed. And for children who are asymptomatic, back that up. Symptomatic, signs at birth, have intracranial findings, even if it's just a few calcifications, they are thought to be eligible for antiviral treatment, which ideally is started before 31 days of age. So we're just in this real time crunch. All these kids, even if they don't qualify for antiviral treatment, are at risk of progressive or late onset hearing loss. And there is treatment, and I use that term very broadly, not just medication, but there's treatment for all kids. So what do I mean by that? So the antivirals, valganciclovir, there's one type that is given right now for the most severely affected. It is a 6-month course. Like I said before, it is no walk in the park. And, there are some studies in rats that show, possible teratogenicity. So it's not a decision to be taken lightly. But for everybody, early intervention, that like developmental monitoring, making sure that if these kiddos have some like speech delay, that they're getting those supports right now instead of a watch and wait. You can also manage the existing sequelae. So, to know, oh, my child has hearing loss, we're going to pursue, sign language and or hearing, aid or cochlear implant, to manage those sequelae. Monitor for new sequelae. Hearing loss in congenital CMV, it can really progress quickly and it can be late onset. So it's important to monitor for that, as well as, also those developmental delays. And then family support. I mean, I think this is huge. And I think one of the most healing things for me has been connecting with other families and just like, people who get it and really being able to, to feel understood and supported and, to rally your network of people that, can help you. So this is why I think everyone can be treated. But there are certainly barriers, right? Change is hard. And so to get the, right now, to get the specimen for testing or for screening, right now, the preferred specimens, like I said, are saliva, which is a little kind of Q-tip swab, buccal swab in the cheek, or a urine. Now, getting a urine on like a 1-day-old is really hard. We would not cath these babies. And so you get this like little sticky bag. It looks like a Ziploc bag and you stick it on there under the diaper and you hope that they pee, which babies don't usually urinate much in those first few days of life. Then you have to, goodness. Then you have to send that to the lab, and did they pee enough, and it can hold up discharge. Like the urine bag is really, really hard. The saliva swab, that is another option. It can be done right now with point of care testing, but it's really, you have to have kind of this one specific machine for it. And I think actually like because of the availability of some saliva swabs in industry, that has really opened up the doors for a lot more screening programs in hospitals, which is great. But it's a whole new system. And so, it's a barrier, right? We have to adjust. And then, like I mentioned, dry blood spot is just not as sensitive. Depending on the lab it goes to, it could be as low as 60% sensitive, up to low 80% if you send it to Mark Schleiss's lab in Minnesota. There's a little plug. So what are the different approaches to testing or screening for congenital CMV? So we can do hearing targeted screening, meaning the babies who fail their newborn hearing screen or are found to have hearing loss are then tested for CMV. This actually only detects around 7% of all comers with congenital CMV. And actually, it misses 43% of the babies with congenital CMV who will develop hearing loss by 2 months. And that's because the hearing loss associated with congenital CMV, especially earlier on in life, it can fluctuate, which is crazy. It can progress really rapidly. It can also just be like somewhat like slightly delayed onset, but still present by 2 months. So it's, we're catching over half of babies who will have hearing loss by 2 months, but not a whole lot of, only 7% of all comers. And then there's routine or universal screening. You just screen all the babies. That'll catch them all. But, people will argue for better or for worse. Here we go. So, there are some challenges, and I think also opportunities in screening. Congenital CMV is rarely a life-threatening condition, and most of the conditions I think currently screened for on the newborn, screening tests are life-threatening, but neither is hearing loss. There are some exceptions there. It's an infectious disease versus a heritable, which is different than the other conditions that we screen for. But, it is actionable. And, there are increasing opportunities for low-cost point-of-care testing that, can run many specimens. And I think that could really, make this universal testing feasible, screening, I should say. And there were some really exciting pilot projects going on. Minnesota has got some really cool work going on. They're screening, I think it's like 30,000, maybe 25,000 infants for CMV using saliva, urine, and dried blood spot. So that will be really cool to kind of see what their outcomes are. And I think that will then, help us really inform these early screening initiatives. I'm going to just breeze over this. So the recommended uniform screening panel, as part of the foundation, we did submit an application in the fall of 2021. We just got some, it's not like reviews or comments back and some recommended changes that we hope to address. So, I think this review process, I think here I put 3 to 5 years. That was probably optimistic, but we're recommending, screening with saliva and then following that up with a urine PCR for confirmatory. And that's because, babies nurse and there can be, breast milk transferred CMV that, could create a false positive for a saliva swab. So you need that confirmatory urine. So hearing targeted screening, this is kind of my big picture. It misses most cases. Yeah, that's right. It misses most cases of CMV, but catches some. But I think heck, it's better than nothing. And, sometimes you just need to start small and develop that infrastructure and then build upon that, as is feasible. Universal screening, so that would detect all infants, possibly more challenging to implement. I think this is a gold standard to work towards. Again, this is my editorializing. I think this really needs to happen. So in terms of state regulations and policy, it looks like some of my graphic design here has shifted in my slide. That's fine. Ignore the purple. So the state regulations and policy around congenital CMV are gaining momentum, super exciting. I feel like over the last year, every time I blink, every couple of months, there's another state that has passed legislation. Really, I'd like to see screening not be, initiated by legislation, right? I'd love it to be, public health researchers and, pediatricians and coming together and deciding, this is the right thing to do. But right now, this is kind of where we're at. So you can see kind of that teal turquoise, that's where a screening or education law is enacted, meaning like maternal education. And so there are some laws proposed. Recently, Minnesota, it's really exciting. So Minnesota passed the nation's first universal screening, universal CMV screening legislation, although they passed the act, but it wasn't that which created the program. Then the public health commissioner and the kind of their newborn screening review committee had to review it and decide whether to recommend it. But that all passed. So knock on wood, early 2023, universal screening for CMV is going to be happening in Minnesota. And I think we're all watching them, very closely and very excited to see the results of that. So how do we test for congenital CMV? There are three kind of big options. Maternal testing, right? If one was pregnant, if you got antibodies before a woman was pregnant and then tested again after, if she hadn't been exposed to congenital CMV or to CMV, you might see a seroconversion in pregnancy if she was exposed to CMV. That would that's not very sensitive. The windows for seroconversion are, quite different, and it's really doesn't really tell us a lot about the exposure or whether or not the fetus will be infected. Of course, for the fetus, can see sometimes things on ultrasound if there are, severe sequelae, and amniocentesis, which in itself is not without risk. For newborns, PCR has really become the preferred method. So urine or saliva are the preferred specimens. You could do viral culture. It's really not done too much anymore. It's not a quick turnaround. It's not good for screening or, large scale programs, but I suppose you could on the individual patient. So speaking of testing or screening for congenital CMV, so diazorin has actually come out or has developed, and it's currently undergoing FDA approval, or under review. But they have a product it's the Simplexa, but it's for congenital CMV, the Congenital CMV Direct, which I'm really excited about because I think that this, might be a game changer in terms of how we can screen babies for congenital CMV at birth. So just kind of a overarching, and I'm a developmental pediatrician, so pardon me, for my explanation as I'm kind of going to breeze through things. But what's really cool about this is that you can use either saliva swab, or you can use a swab. It's like a Q-tip, flock swab, saliva or urine, you can do the urine, from a bag or a container, but it doesn't have to be much, which is really cool. The throughput is, 1 to 8 samples per run, and the run time is only about 70 minutes. The really cool thing here is the hands-on time is about 1 minute per run. I think this, I think this is going to be, it is compatible with the other Simplexa, tests that are out there. Other microbiology labs may already be using some of these products. So it is my hope that this actually will be really easy for some larger healthcare institutions to, implement and integrate into their flow in terms of making testing more feasible. The intended use for this is screening, meaning that, you would have to follow up a positive saliva result with a confirmatory urine, again, because of the possibilities in false positives. This is just, this is a table, and now I'm seeing that these numbers are pretty small, but the clinical agreement, in their studies has been, really encouraging in terms of both saliva and urine. So I'm really hopeful. I've been saying this, because of COVID, everything got pushed back, but I've been waiting for this for a year, no, probably 2 years now. So I think they're getting close. I'll just wrap up here by talking about the National CMV Foundation. So our mission is to prevent pregnancy loss, childhood death, and disability due to congenital CMV. We are a small but mighty organization. We have 2 full-time staff, and so a lot of what we're able to do is really driven by our families and parents. And so you can see these are some of the parents that have shared their stories with us. Or, shared their stories, and their pictures are on our website, and their stories are on our website. And, you can really see the degree to which these babies are obviously affected or, not so obviously affected. And then, I think just seeing the faces of their family really kind of helps, make the connection in terms of this disease really impacting lives. Check out our website. There's lots of cool resources on there. So I'm going to stop, and thank you so much for having me. This is a picture of Odessa now. She goes to a school for deaf children, and we went to this kids museum, and the first thing she does is gets her lab coat on, gets a play otoscope, and is checking the ears of all the animals, which they check her ears often at school. So I just love to see kids playing out real life. So I'm happy to take questions. Thank you.
Thank you so much, Dr. Pesch, for that insightful talk. We really appreciate your time. It looks like we have a few questions that have come in during your presentation. So I will go ahead and start with this first one. Any thoughts on the next states that may vote on or pass universal screening legislation now that Minnesota has set the precedents?
Yeah, I think there's been a lot of action towards that in Massachusetts, which has been pretty exciting. I think a lot of people are watching Minnesota closely to see kind of how that plays out. In Canada, Ontario has been doing this since 2019. So that's universal screening. So people watch them first. And then now in Canada, we're seeing additional provinces turn. So Saskatchewan has been the most recent one. So I think, I think there are a lot of people or a lot of states that have already implemented hearing targeted screening that, may then consider expanding. And, newborn screening doesn't usually go through or isn't usually implemented through legislation, right? CMV is kind of a unique condition in that sense. And so, I'm hopeful that we will see more and more state health departments include CMV, and it may not need to go through legislation.
Okay, great. Can you discuss any anticipated implementation pitfalls or challenges labs could expect when considering a congenital CMV testing program that includes primary screening followed by confirmation testing? Is there a concern about the ability to obtain the confirmatory urine specimen? Would the clinician report the first result or wait until the confirmatory testing result?
Yeah, that's a great question. Well, I think when people talk about different ways of universal screening or any sort of newborn screening, there's centralized screening where, all the samples are sent to one lab or so in the state. And then, there's point of care screening, it's done in a local lab or on the floor or, whatnot. And I think in the case of CMV, I can see arguments in both directions, and it really depends on the specimen type. But if we're talking about saliva swabs as kind of the first screen, which is the most common and really what we're seeing kind of in most places, then I think, that can be done relatively easily with a very quick turnaround time, on the floor in the hospital. And then, after that, you would pursue the confirmatory. I think there is something really nice about having a captive audience to get that confirmatory testing. And so, meaning we've seen this with the newborn hearing screen. So here in Michigan, we, screen babies in the hospital. And if they refer or fail, then they are supposed to follow up as an outpatient for a repeat screening or diagnostic test. but our loss to follow-up rate is 50%. And that's with, some really amazing program coordinators trying to track down these families and texting and talking to PCPs and so forth. So I think it's really going to be critical to, have a tool or that can be used, that can have that fast turnaround time. So I guess what I'm saying is I think saliva can be done relatively quickly. And if there is a positive, we do have to confirm it, because false positives can occur with breast milk, or, even just being born, you can pick up CMV. But then, the urine confirmatory, if that can be run in-house too, it shouldn't be too difficult to get. And, that being said, when we collect urines on babies, it's not like a cath or anything really like invasive. For babies, what you do is it's like these little like Ziploc bags with like sticky on it. So you stick it on under the diaper, and, you wait for them to pee, and you can run the test usually off a pretty small amount. So, there will be difficulties in terms of that urine collection, possibly delaying discharge, because babies really don't urinate too much in that first couple days of life. They hold on to their fluids just physiologically. So I think that will be a challenge. I think, it's an opportunity to really connect with the primary care physician and educate the families about the importance of, getting that urine. At our hospital, sometimes when we do a urine collection, and the family's waiting for the baby to pee, the baby isn't peeing. Sometimes we'll discharge families home with a little, we call it like a to-go baggie, and it's got all the supplies you need to do a urine collection at home. It's relatively simple, and it doesn't need to be like super sterile. And so they can then return that sample to the lab. But anytime you let a kiddo go, you do have that risk of loss to follow-up. So I think, as with our newborn screening, it's always going to be, or newborn hearing screening, it's always going to be something that, we're going to work on and work to improve.
Okay, great. And there is another one. We know there is a correlation between education and the annual incidence of newborns' disease and conditions, including congenital CMV. Is there any push from the medical community to drive education and tools to improve women's knowledge of CMV during prenatal care, while individual state legislation takes track? If not, is there any reason why the lack of obstetrical providers' involvement?
Yeah, absolutely. So I think there has been a push. Again, it's first kind of come through legislation, which has been, is really unique to CMV. I think, and not being an obstetrician myself, I can speak to what I've kind of heard and seen, but of course I'm not in the trenches taking care of these patients in the same way. For the most part, I actually think the knowledge among obstetric providers in the United States about CMV is actually pretty low. And I think that's just because it hasn't been a condition that's been really prioritized by the professional organizations. So, a lot of people, CMV moms like myself, when you first find out about this, think like, why didn't my provider tell me about it? And yes, I think that's, definitely an okay feeling to have, and, a good question to ask, but a lot of the times the providers themselves aren't really that educated about it. So I think, the push, has to come from even, higher, so the professional organizations, and as well as like outreach to the providers and women themselves. So there are several states that have some education mandates in place. So, there's materials being distributed, public health campaigns. Those, unfortunately, have not seemed to really move the needle in terms of awareness of congenital CMV, at least in Utah. And Utah's been doing this for the longest. And, the awareness about CMV among women has really stayed around that 9 to 10% mark, despite, billboards and so forth. So, what I think is probably going to happen is that, and it's unfortunate, but this is what I think is going to happen is as we keep screening more babies, everyone is going to know somebody with a baby with CMV. And to tell you the truth, everybody does know a baby with CMV right now, or a person affected by CMV. It's 1 in 200. I mean, it's so common. We just don't know that we know them, right? So as more babies are getting screened, I think we're going to have more and more, healthcare professionals, parents, just the general public asking these questions. Why aren't we talking about this? Why aren't we, talking more about risk reduction or prevention in pregnancy? And I think, it's kind of this roundabout way, but I suspect that that's how we're going to start to really see the change. And, in some ways, the change that we've seen thus far has been really spurred forward by angry moms of kids with CMV. These parents that are like, how did this happen? And, myself included. And there's kind of these big systems issues. So I don't want to come across like I'm pointing the finger at one particular provider, or, it's pediatricians too. But I think that's really how we're going to see this move forward. And I will say that the ACOG has been publishing more about CMV and had a really great panel at their last conference. So I think that I think the tides are turning.
Okay. Well, I think we've come to the end of our time for today. I want to thank you again for this very, very interesting, insightful presentation and your time. If you want to get a hold of Dr. Pesch, her contact information is on the thank you screen that's up right now. I also want to thank all of you that have participated and joined us today, and I hope that you continue to enjoy the rest of the event and enjoy the rest of your day. Thank you very much.
Thanks for having me.